series. So before we start, I would like to thank the organizers, the SSBMT, Dr. Ahmed Al-Askar, and everyone who helped, as well as would like to thank Takeda for sponsoring the talk today. So it is our pleasure to have Dr. Hanjo Lee from MD Anderson. He's an associate professor of medicine in the Department of Lymphoma and Myeloma at the University of Texas, MD Anderson. He's the Jessica and Jeffrey Brew Edward Professor of Lymphoma Research. He received his medical degree from the University of Buffalo State, University of New York. Dr. Lee completed internal medicine residency at North Shore, Long Island Jewish Medical Center. He completed a fellowship in medical oncology in Roswell Park Center Institute. He's a lymphoma physician with a special interest in classical Hodgkin lymphoma. His research focuses in novel targeted treatment development and medical education. And he's the primary investigator of several phase 1-2 trials. So we're happy to have you, Dr. Lee, today, talking about management of classical Hodgkin lymphoma relapsing after autologous transplant. Dr. Lee.
Thank you so much. Let me borrow the slides now. Can I share the screen? Perfect. Thank you so much. Okay. Okay. Thank you so much for the invitation. Thank you for the Saudi Society of Blood and Marrow Transplantation for this opportunity to speak on my behalf of the organizers, Takeda. I am here to speak to you guys about how I treat relapsed Hodgkin's lymphoma, especially in the post-transplant setting. And this is my first time giving a talk in Saudi, so assalamu alaikum. That's the first word I learned. So I wanted to thank you guys for the invitation. These are the conflict of interest, and this is so the current landscape of Hodgkin's lymphoma. I will not spend too much time at all at frontline therapy. I will spend most of my time talking to you about second line therapies, especially in the second line and the post-transplant. How can we keep the patients in remission? And obviously the post-transplant failure setting and those patients who are relapse refractory that cannot even were ineligible for autologous stem cell transplant. So the key things that I will point to and focus on is to try to improve the pre-transplant PET negativity prior to autologous stem cell. And then for those patients who've successfully completed autologous stem cell transplant, how can we reduce the relapse rate post-transplant? And those patients who fail autologous stem cell transplant, is there some novel therapy treatment options that we can use to utilize to get them back into a complete remission? And possibly, delay allogeneic transplantation, or is there a substitute for allogeneic stem cell transplantation? The outlines are listed here, trying to improve the outcomes of transplant and for those who relapse after autologous stem cell transplant. So what percentage of patients go to transplant in the United States where I practice? There's about 9,000 patients that are newly diagnosed per year in the United States to get classical Hodgkin's. Out of that, about 1,000 of them are above the age of 70, frail, that will not be a good candidate for standard of care therapy. And as you can see, there's early stage favorable, divided early stage and unfavorable, and then early stage with bulky disease, and then the high IPS scores in the advanced stage settings. There's about 10% of the patients who fail early stage favorable, 15% will fail in the unfavorable setting, and about 20% will fail with bulky disease. And about 25% of the favorable will fail, and about 30% of the 30% of the patients will fail if they have a high IPS advanced stage. In total, about 17% or 1,400 patients will fail. Out of those 1,400 patients, they will get platinum-based chemotherapy. That's standard of care. ICE. Platinum-based chemotherapy is most commonly used. GVD, other platinum-based chemotherapy, ESHAP has been, all of these have been studied and fairly similar in terms of its efficacy. And you can see about 70% of the patients will get into PET negativity, and about 75% will be cured with the autologous transplant. And about 25, you can see about 245 patients will fail the autologous transplant. For those with a PR, partial remission at PET, obviously they will be less likely or less successful with autologous transplant. And about 50% will fail auto transplant. And those who do not respond to platinum-based chemotherapy, about 15% of them will need some other type of treatment that will be lumped into those patients who fail autologous stem cell transplant. Obviously, the novel agents that are currently being already developed, FDA approved, and are being developed in these settings is the brentuximab vedotin, which was approved back in early 2010s, and the PD-1 inhibitors, nivolumab, pembrolizumab in the United States that are approved. There are some other agents that are approved in China and elsewhere, which we can discuss, and I'll allude to them at the end of the talk. Brentuximab vedotin for classical Hodgkin's relapse refractory. As you can see, these are the pivotal phase 1/2 study by Dr. Yunus at MD Anderson, who did the original studies. Overall response rates in this relapse refractory setting, overall response rate of 75%, and 1/3 of these patients getting into a complete remission. And this led to the pivotal approval of brentuximab in classical Hodgkin's lymphoma. And as you can see on the right, this is the ATHERA study, the largest post-transplant setting, giving brentuximab for these high-risk patients that have risk for relapse from progression after autologous transplant, and clearly demonstrating that brentuximab is highly active in this setting. PD-1 inhibitors, obviously, you can't have a Hodgkin's talk without having a PD-1, and nivolumab was the first development. As you can see, this is the pivotal phase 2 study of 3 cohorts of BV naive, of those patients who had BV after stem cell transplant and those who had BV before and after stem cell transplant. And in the whole cohort, overall response rate of 72% and CR rates of 33%. And you can see the waterfall plot demonstrating majority of the patients benefiting from a PD-1 strategy. Therefore, this was also approved by the FDA for use in 2016. And this is the pembrolizumab data with the Keynote 87 design, very similar to nivolumab Checkmate 205 study. Patients who had autologous transplant and BV, who were ineligible for autologous stem cell, who have failed BV, and those who failed, who have not been treated with BV and failed autologous transplant. And you can see the primary endpoint was overall response rates, and looking at survival. The response rates you can see here, overall response rates anywhere in those subgroups, 64 to 78%. And complete remission rates anywhere between 26 to 32%, which is comparable to the nivolumab data, and which ultimately led to the FDA approval for these 2 agents for in the relapse refractory settings. Now back to improving the auto transplant. How can we improve the auto transplant? And that's the quick question, because if patients get cured with auto transplant, then we don't have to worry about those patients who relapse. So who are these patients? And this is Dr. Moskowitz data in the early 2012, demonstrating that patients who are going into an autologous stem cell transplant, they need to achieve a PET negativity, and that is the key. So all of the development in the first salvage setting is to make sure that everybody achieves a complete metabolic remission prior to autologous stem cell transplant. As you can see, compared to those who had PET positive disease going into autologous transplant, their PFS is dismal. As you can see, about 30% of the patients were in CR at only about 12 to 18 months out. So this slide is one of my favorite. This was a slide that was given, this was the question that was asked in Lugano, 2018. As you know, I mean, not Lugano, this was the Cologne meeting for Hodgkin's lymphoma. And last year, unfortunately, it was canceled secondary to coronavirus. But in 2018, they asked this question: what reinduction salvage regimen would you recommend? And we had over 300 Hodgkin's lymphoma experts, and they were asked to choose which is their go-to regimen. And you can see 14% throughout the 7 different choices. That represents there's no such thing as a perfect regimen or the ideal regimen so far in the salvage setting after failing AVVD or escalated BIACOP. So how can we improve the pre-autologous stem cell transplant setting? So how about adding brentuximab to, the platinum-based chemotherapy? This is a no-brainer, okay? So BV added to augmented ICE. And what I wanted to show you is, okay, the patients, 12 patients out of 45, that's about 25% of the patients, were able to get PET negativity with just the brentuximab. That tells you, hey, because many of my patients that come in to come in for consultation, they just fail AVVD, they just fail escalated BIACOP, and they don't want to go to, like, Dr. Lee, why are you giving me chemotherapy when I just fail escalated BIACOP? Okay, so I do agree that I want to give them a opportunity to get into a complete remission without getting the harsh ICE chemotherapy, ESHAP, GND. So I do agree that this is very interesting to me. About 25% of the patients were able to get into a complete remission. And with ICE, the augmented ICE, as you can see, the majority of the patients, 22 PET negativity on top of it. So 44 was able to undergo a complete metabolic remission. But what I want to show is that you can see the PET negative after BV alone or PET negative after BV plus augmented ICE. The event-free survival is very similar and statistically insignificant. So therefore, hey, if you could get into a complete remission after BV single agent, then you can go get autologous stem cell transplant consolidation afterwards. And this is all the brentuximab plus platinum-based chemotherapy salvage regimens. But you can see that the complete remission rates are not that much better than platinum-based chemotherapy alone. So you can see anywhere between 70 to 80% with the combination of brentuximab plus ICE or platinum-based chemotherapy. And with platinum-based chemotherapy, we quote anywhere between 65 to 70% complete remission rate. So the brentuximab, the addition of the brentuximab is about, I would have to say 10 to 15% of CR rate. So, if you could get into a complete remission with brentuximab alone, then hey, maybe you don't even need to, or you could forego these platinum-based chemotherapy. All right, so then the obvious next idea is, how about nivolumab plus platinum-based chemotherapy? Obviously, nivolumab ICE is the next thing that we studied here at MD Anderson with incorporation with City of Hope. And what I want to point out to the audience here is that with nivolumab alone, single agent nivolumab, after a majority of the patients, you could see that they failed AVVD chemotherapy. We did have one escalated BIACOP, that patients with single agent nivolumab, 77% were able to get a complete remission and were able to move on to autologous stem cell transplant without receiving a platinum-based chemotherapy. And I thought that was very interesting. And this is the pembrolizumab in combination. This was not a sequential therapy, but pembrolizumab plus GVD, in that you can see that the complete response rate after 2 cycles of pembro GVD was 91%. So you can see the pembrolizumab is adding about 20%. And the question that people are going to ask is, hey, how about if you do pembrolizumab alone? Can you get to transplant with pembrolizumab alone? And that will be very interesting. And to save many of these young patients of the GVD toxicity of the chemotherapy, and a very reasonable toxicity, majority of which is probably coming from the GVD, the chemotherapy. And this abstract was presented at ASH 2020. How about the most expensive regimen? Okay, the brentuximab nivolumab regimen. As you can see, the overall response rate 82%, comparable to others, and a complete remission of 61%. So this was in the first line setting, first salvage, right before autologous transplant. So this is very interesting. You could see the different studies and the complete remission rates. And if you look at it, hey, if Dr. Lee, if you can get 77% complete remission rates with nivolumab alone, hey, what's going on here? So many of the questions are being raised, like, hey, we will need a large a phase 3 study in order to answer these questions. And these small phase 3 studies, you can see that the complete remission rates are very variable between studies. However, it is letting us know that the nivolumab brentuximab is very active in the second line setting for those who did not have these novel agents in the front line setting. Oh, this is the the newest of all the combination of the brentuximab, nivolumab, and ipilimumab CTLA-4 inhibition. And you can see the overall response rates, 82%, very comparable to the BB-Nivo and the Nivo-ICE and the Pembro GVD data. Overall response rates and the BV-Nivo very comparable to the BV-Nivo that was done by Alex Herrera in the City of Hope that was published in Blood. So very comparable, but as you can see, they're moving on with further studying this triplet combination of BV, Nivo, Ipi. However, the 73% CR rates, it's not really that much better than Nivo alone. Then the question ultimately gets raised, hey, what is the Ipi really contributing to the response rate and the complete remission rate? And these will be a very, interesting question to be answered. And I know that the authors of this paper that was published in Lancet are planning on a bigger phase 2 study to figure out what exactly is the contribution by the IPI arm. So how do we improve the autologous stem cell transplant? After the auto transplant, how can we make sure that these patients who went through intense chemotherapy and autologous stem cell transplant, we keep them under complete remission? So obviously, give them more treatment, brentuximab, pembrolizumab, brentuximab, nivolumab. So you can see the theme of these studies. You can clearly see this is the Athera study, the phase 3 study, and you can clearly see this was developed back in the early 2010s. This took relapse patients with high-risk features, meaning they relapsed less than 12 months, relapsing with extranodal disease or refractory disease to frontline therapy. And they were given autologous stem cell transplant and randomized to brentuximab versus placebo. And you can clearly see in the brentuximab arm, the median PFS was 42 months, and the placebo was 24 months, clearly demonstrating the benefit of brentuximab maintenance in these high-risk patients. How about pembrolizumab, Dr. Lee? This phase 2 study reported by Arman et al. In Blood 2019, all patients post-autologous stem cell transplant was given 8 cycles of pembrolizumab, a flat dose of 200 milligrams every 3 weeks, and the PFS of 82% at 18 months, clearly demonstrating promising results. And we will await the long-term follow-ups, and clearly demonstrating that this may be equivalent or slightly better than brentuximab, but I don't know if this study will have another larger study given this data. BV plus Nivo maintenance. This was presented by Alex Herrera from City of Hope in the last ASH in 2020. And you could see 18 months PFS, 95%. Okay, larger study than the Pembro single agent consolidation. So this is very exciting. Obviously, the brentuximab, it's really hard to give brentuximab consolidation, as you know, many of the patients will have peripheral neuropathy. As in my clinic, many patients want to get off of brentuximab very frequently, and so these giving consolidation therapy is fairly difficult, but the nivolumab consolidation is fairly well tolerated, just like the pembrolizumab data. So this data of 95% at 18 months is fairly exciting, and obviously this will lead to possibly an FDA indication. So what are we doing for these patients post-autologous transplant failure? Novel agents that are being developed. Obviously, I cannot give a talk in any lymphoma without talking about cellular therapy. CAR T. Even the patients are coming in with little papers that say, Dr. Lee, I checked my Dr. Google, and there's a CAR T therapy for this Hodgkin's lymphoma, this follicular lymphoma, this diffuse large B-cell lymphoma. So, the cellular therapy is going to be the next idea or the theme that will be coming down the pike. And the allogeneic transplant, obviously, you guys are transplanters, so you guys know more than I do. But allo transplant for these young patients have not been ideal, and for the bang for the buck, for the amount of toxicity has not been justified. So many of the patients that are coming in are trying to avoid allo transplant or delay it as long as they can. So the first novel agent that is on the cusp of getting FDA approval is what's known as camdenulumab for relapsed Hodgkin's lymphoma. This was presented in Lugano and again in ASH 2020. This is the anti-CD20 antibody attached to a pyrobenzene diazepine payload, and that goes after a CD25 tumor target, and then it internalized, drops the payload that causes DNA breakage. Okay, this is a very, classic formulation of the SGN35 brentuximab CD30 targeting, payload attach, internalize, and release the payload. Unfortunately, and it was very active, and this was the response data. Overall response rate, 80%. This is looking like FDA approval, and a complete response rate of 38%, comparable to any of the PD-1 checkpoint inhibitor. This is a slam dunk for FDA approval until what? Until the toxicities came out. Until the toxicities came out. What happened to that slide? Until the I apologize. The toxicity slide has been deleted somehow. So this one had a Guillain-Barré toxicity, about 8%, about 10% of the patients had this polyneuropathy. And we had 2 patients here at MD Anderson that were being treated on this protocol. And it was fairly scary. And we had to, and one of my patients had this phenomenon, and we had to admit him to the hospital, and we had to do plasmapheresis. And so if you are a small institution or a small clinic and do not have access to plasmapheresis right away, this will be a tricky drug to implement, just like the CAR T-cell therapy, where if you're not capable of treating what we call neurotoxicity, ICANS, this will be a very tricky drug to implement. So this will be, I do believe that the FDA will approve this drug. However, this will have to be adjusted for the risk management of this disease, because the Guillain-Barré is a toxicity that will have to be mitigated in order for this drug to be approved. But the numbers, the overall response rate, and the complete remission rates are comparable to all the drugs that have been approved by the FDA. So we are very excited about this drug, but this will require risk mitigation for many of our patients. The other compound is the bispecifics, the FAM13, the CD30-16 bispecific antibody plus pembrolizumab. This was recently I believe published by Blood by Nancy Bartlett and Dr. Ansel's group. And this is a bispecific antibody that brings the Hodgkin's lymphoma cells with the NK cells in hopes that they will be able to kill the Hodgkin's lymphoma cell. And in Lugano, they presented a very high response rate, 88%, and a complete remission rate, 46%. Once again, we're getting to that the level of getting FDA approval of overall response rate and a very high complete remission rate, but in combination with pembrolizumab. So this will be very interesting to see how this gets played out, how much of it is the AFM13 and how much of the efficacy is from the pembrolizumab. So we do have a study. This makes it a little more sexier. We try to incorporate the FAM13 with cord blood NK cells. So now we're bringing in the NK cells. So we have banked umbilical cord blood CD30. We culture them and give it feeder cells to activate them, expand the cells, and get them ready for infusion. We give them lymphodepleting chemotherapy like CAR T cells. We infuse on day 0, and we are able to give multiple doses of FAM13. So far, we have treated 3 patients, and very interesting, no ICANS, no neurotoxicity, no CRS. So this is very exciting data. So we're having some PRs and VGPRs. We're optimizing the number of the NK cells. So this will be studied further in MD Anderson. So if you have any patients who are interested in a very novel approach of FAM13 plus NK cell, please contact us. This is another FT500 NK cell therapy plus checkpoint inhibitor. This is a Fate Therapeutics sponsored study, and they have a NK cell product that can be delivered off the shelf, given in combination with checkpoint inhibitors. And this also is showing very promising. 3 patients have been gone through. 2 patients are in complete remission. Obviously, these are heavily pretreated post-autologous stem cell transplant, 1 stable disease, no side effects so far in terms of CRS, and no ICANS for these immune effector cell therapies. So we are very excited in pursuing and developing these treatments. And obviously, the next treatment that is being developed here at MD Anderson is the CD30 CAR T cells. And this was the paper by Dr. Ramos, JCO last year. And CD30, obviously a clear target for Hodgkin's lymphoma, and a proven target. So, the CD30 CAR T is a no-brainer in development. As you can see, about 30%, 30 patients were treated, 37 patients were treated, and you can see the different types of lymphodepleting regimens that were used: bendamustine, fludarabine, Cytoxan, fludarabine. The sponsors are going with the bendamustine, fludarabine as the lymphodepleting chemotherapy for this trial because of the high overall response rate and the 73% CR rate. So this is the highest CR rate so far demonstrated. So we are very excited in this large phase 2 study that is coming up. So you can see very few CRS, no ICANS, and the most common immune-mediated toxicity was skin rashes. And you could see the survival curves and the progression-free survival. We're hoping that with the bendamustine fludarabine lymphodepleting chemotherapy, we will be able to flatten this PFS curve. Obviously, the 3-year PFS of 36%, we're hoping that will be better with the combination of bendamustine fludarabine only for these patients. Clearly, you need the fludarabine in order for that. That's based on the diffuse large B-cell lymphoma data. Clearly, you need this, the alkylating agent plus the fludarabine in order to have that great expansion of the CAR T cells. So we are very excited that this protocol will be open, is open right now and are enrolling. So we look forward to anyone who's interested to come down to our sites. This is the novel PD-1 inhibitors. Obviously, tislelizumab developed in the Chinese population, a very high overall response rates, 85.7%. But majority of these patients that got the tislelizumab were not auto transplant failures. These were mostly 2 lines of chemotherapy failures and a very high complete response rate of 61%. So I know that the company is developing this in Europe mostly because of the dominance of pembrolizumab and nivolumab in the United States. So we look forward to the larger, the phase 3 studies coming out. And you could see the very good PFS rate here by tislelizumab. We are looking forward to the classical Hodgkin's lymphoma data. And the PD-L1 inhibitors in relapsed refractory classical Hodgkin's lymphoma, these are all patients who have failed or ineligible for autologous transplant. Overall response rates, 41%, slightly lower than the PD-1s that were discussed in nivolumab, pembrolizumab, CR rates of 16%. So this is a very interesting, I don't know how this will be played out, but I know that they're working on to bring this on to for classical Hodgkin's lymphoma. Other novel agents, there's mTOR inhibitors plus HDAC inhibitors, lenalidomide. There's other agents who are participating in ibrutinib, BTK inhibitors. Obviously, the cellular therapies are the main attention getters right now because of the very high response rate and the complete remission rates. But these combinations will be studied moving forward. And allotransplant obviously is clearly a possible cure for many of these patients who fail autologous transplant. And many of our patients who fail multiple lines and exhaust all the options do go to allogeneic transplant. And I know there's lots of activity in the allotransplant setting, but these are numbers that are this meta-analysis of large allotransplant data showing 3-year PFS rate, and overall survival rate showing 30 to 50% PFS and overall survival respectively. So obviously these are not a very intriguing numbers for many of our young, 30, 40-year-olds that have failed autologous transplant for the amount of toxicity they have to go on. So we look forward to, all these treatment options are in flux, and obviously we will see how this all gets played out. But this is a very exciting time in classical Hodgkin's lymphoma moving forward. So with that, I'll take any questions.
Thank you very much, Dr. Lee. It was very, really entertaining. I really enjoyed it. And a lot of exciting news for the future for Hodgkin lymphoma patients. So,
yes.
Yes, definitely. So I think along that lines, until I get more questions, I'll ask myself a question regarding allogeneic transplant. Do you think it will be dead in, let's say, 5 years? Drugs, checkpoint inhibitors, the CAR T, CAR NK, BiTEs, all of these.
That's a very good question. I do not believe allotransplant is dead. A lot of people have, predicted, but our transplanter team will disagree that there will always be allotransplant available. As you know, allotransplant is a cure for a small fraction of patients, so it is a very powerful tool. But as you know, the allotransplant carries a lot of treatment-related mortality and treatment-related complexity and toxicity, which are fairly expensive for many of our patients to tolerate. So I do agree that we're trying to improve the allotransplant, but now it's becoming pushed out to a later phase of treatment options for many of the patients. But yes, I don't think it will be dead, and I do believe it is an option for a certain population that are able to understand the risks that are involved. They have a perfect match and support that they could go through the allotransplant.
And if they go to allogeneic transplant after failing checkpoint inhibitors, is there anything that you would recommend to mitigate the risk of acute
So that's a very good question. Obviously, there have been reports, retrospective studies demonstrating that there's an increased risk of GVHD giving checkpoint inhibitors prior, or giving checkpoint inhibitors to get them into a complete remission so that you could get them to transplant. So some of our transplanters recommend getting them into a complete remission with the checkpoint inhibitors and giving some chemotherapy right before going into allogeneic transplant to mitigate some of the GVHD toxicities that can occur getting into a complete remission with checkpoint inhibition.
Great. Okay, so I guess we have a question from Dr. Benjamin Osman. Would you recommend brentuximab or checkpoint inhibitors as maintenance post-auto transplant if patients was refractory to brentuximab but sensitive to checkpoint inhibitors prior to transplant?
Oh, that's a setup. I think that's a setup questions to say, yes, you should go with pembrolizumab or nivolumab. Unfortunately, the nivolumab data was with combination with nivo plus brentuximab. I think pembrolizumab is a reasonable option based on the small data set that was published in Blood by Dr. Arman in 2019. Pembrolizumab is better tolerated. It does have a different toxicity. As you know, pembrolizumab or any of these checkpoint inhibitors are better tolerated than brentuximab. However, a very small minority, about 8 to 10% of the patients can have colitis, pneumonitis, endocrinopathies, DKA. I mean, these are very unpredictable side effects that are very difficult to handle. It is small, but it is real. And I have tons of patients who are getting frontline checkpoint inhibition. It's fairly tough when they have these kinds of colitis, pneumonitis, pancreatitis, hepatitis. These things are very tricky, leads to a very prolonged treatment holding. And so I do agree that pembrolizumab, if I was the patient, if I was betting, which I don't bet on Sundays, if I was a betting person, it would probably be pembrolizumab.
Okay. So Dr. Ahmed Shumar asking about using of brentuximab during the salvage pre-autologous transplant. Can we use it, if you use it in the salvage transplant, can you use it after transplant for maintenance?
Oh, yes, that is. Oh, and we have seen brentuximab, what we call Rechallenge with brentuximab, and we do see those patients, as long as they were not refractory to brentuximab less than 6 months. So when you re-challenge them with brentuximab, we have seen significant responses. That goes along with brentuximab and checkpoint inhibition that we do see when patients were held, what we call, stop the checkpoint inhibition because of whether it's a protocol treatment where they had only 6 cycles, a limited number of cycles, they were re-challenged with checkpoint inhibition and they responded to checkpoint inhibition. And so those are very interesting. And I have patients who who relapsed or refractory to nivolumab, and I rechallenged them with pembrolizumab, and they responded. So I do agree that even though we called them checkpoint inhibition, they do have some different properties that, I do agree that they do have probably different biological underlying mechanism, even though we called them checkpoint inhibition.
Interesting. Dr. Osman asking about patients who achieve stable disease, how long we should continue checkpoint inhibitors?
That's a I have to look into my crystal ball. So there is no answer to that question, and that's a very frequent question that is raised by my patients. They're like, Dr. Lee, how long? I've been on nivolumab for 4 years now. I've been on nivolumab for 4 years. When do I get off of nivolumab? And there's no answer. I mean, if you respond and you have no toxicity, I continue as long as the insurance doesn't give me problems of paying. Okay, as you know, the manufacturer sticker price on nivolumab for a single dose, I believe, is anywhere between 16 to 20,000 US dollars. So it's not an inexpensive treatment. So I do talk to my patients and say, hey, there's no real answer. You could go to allo transplant, but they're scared. When I say allo transplant, they say, okay, Dr. Lee, I'll continue with the nivolumab. And then, if I want to give them a break, I talk to them about there's no real good data to how to dose this, giving holidays. So I do like the pembrolizumab every 6-week dosing, at least so that they don't have to come back so frequently. So as you know, many of the Hodgkin's patients, they're in their 20s and 30s, and they hate coming back for infusions. And so, I have to negotiate with them, even though, you're supposed to follow, strict medical guidelines. These 30-year-olds, they want to negotiate. They're like, Dr. Lee, can I get one dose off? One dose, please. And then I'm like, I think you should continue, but Dr. Lee, I need to get married. Then I'm like, all right, fine. Then we have to negotiate many of the times.
How important do you think is the depth of response before autologous transplant? I mean, we do.
So that's a very good question. Obviously, it's clear, and it's a no-brainer. Obviously, those patients who are in complete remission before transplant, before auto transplant, have a better outcome than those who have disease before transplant. Do you need a phase 3 study for that? I mean, that sounds so obvious, but the Deauville scores, and that's where, I have my, Dr. Sarag, who's our postdoc, who's looking at these PET scans and looking at the radionomics to see, what are these characteristics that ultimately determine, is it the Deauville score? And as you know, and Dr. Lee knows, Deauville scores are visual scores. So there's a lot of controversy. Is that a 2? Is that a 3? Is that a 2? Is that a 3? Maybe that's a 4, maybe a 3. And we have these discussions all the time. And so it is not as strict, what I call clear cut, as these publications make it seem like there's a positive and negative. And don't let that fool you. I mean, it's a very controversial area between positive and negative.
Yes. Dr. Ihab asking, is there a role of combination nivolumab and brentuximab?
Yes. Obviously the data are out there. The Alex Herrera paper from 2018 is very interesting. The overall response rates of 80%, complete remission 61%. But we just presented our data showing that single agent nivolumab can give you 77% CR rates. Okay, so why would anyone combine first? That it makes sense. If I was the buyer of chemotherapy, if I had relapse refractory disease coming in, okay, after AVVD or escalated BICOP, I'll be like, hey, Dr. Lee, you know, I want the nivolumab single agent, okay? And if I get into a complete remission, I'll think about the auto transplant. I'll think about the auto transplant. So, you know, that would be the question. I had one patient actually on our trial, on the Nivo ICE trial. Actually, he's from Dubai. He was a hedge fund manager, hedge fund. He went to Germany for frontline therapy. And he got escalated BICOP. And you guys know escalated BICOP, that's fairly toxic. Okay, after 4 cycles of escalated BICOP, he had progression of disease. So he comes to us, okay, and he tells me, Dr. Lee, I just failed escalated BICOP, okay, don't give me chemo. I need something new. Okay, so I put him on the Nivo ICE trial, okay, gave him Nivo. He went into complete remission after Nivo, 6 cycles of Nivo. And I told him, hey, you can go to auto transplant. And guess what he said? He said, no way, I'm going back to Dubai. I'm not getting auto transplant. I'm not getting any more chemo. I'm just going to stick with the nivolumab. Dr. Lee, call me, okay? Call me when the CAR Ts are approved, okay? I'll be your first patient, okay, if I need it. So I do agree that there are people, you know, people who understand the disease that, you know, you're failing if you fail a very intensive treatment like escalated BICOP, auto transplant, what is auto transplant? Basically more chemo. So auto transplant is a misnomer. You know, it's like there's no transplant. There's just high dose chemo. Okay. So if you failed high dose chemo, what is the logic? What is the strategy behind giving more chemo? And so I do agree with many patients who say, Dr. Lee, you know, I don't understand this strategy. I just failed intense chemo and you're giving me more chemo. I don't understand, but you know, unfortunately, you know, we have to follow standard protocol, which is, you know, still in the United States, autologous transplant or high dose chemotherapy followed by stem cell rescue is still the standard of care.
Great. So we have a question from Dr. Benjamin Osman about the use of PET scan for assessing response after checkpoint inhibitors or during checkpoint.
Yes, as you know, PET scans are the standard of care, okay, are the gold standard for assessing disease in Hodgkin's lymphoma. However, measuring disease is very controversial because PET scan, let's look at PET scan. It is not a tumor scan. This is not a tumor scan. This is a sugar scan. Let's be honest. This is a sugar scan. The FDG activity of the PET scan that picks up is a sugar scan. Unfortunately, whenever you have inflammation, and as you know, checkpoint inhibition causes a lot of inflammation, you will see this what I call FDG activity in these inflammatory sites, and that can lead to the upscoring of the FDG activity and an upscoring of the Deauville score. And more recently, and this goes into one segue. I won't go belabor the point. We had patients with coronavirus. Okay. Patients who were on checkpoint inhibition who got coronavirus, their lungs light up. So even though, as a lymphoma doctor, I was like, hey, that looks like a Deauville 2. That's a Deauville 2 because the tumor itself has no activity, okay, and it has shrunk significantly. However, the nuclear medicine doctor read it as a Deauville score 4. Because of this checkpoint inhibition inflammation on top of a coronavirus inflammation. So you will see, PET scan is going to be very tricky to interpret and have to be cautious. And myself and Dr. Sarag, we're looking at these different types of scenarios and how to interpret this PET scan data.
Yeah, definitely very subjective. Okay, so question about, I guess, extremely rare scenario, which is CNS relapse Hodgkin lymphoma, isolated CNS relapse, and the use of checkpoint inhibitor.
Hodgkin CNS relapse.
That's the question, yes.
And checkpoint inhibition. Obviously, there are some data, not in Hodgkin's lymphoma, not in classical Hodgkin's lymphoma, more in diffuse large B-cell lymphoma. There are activities of checkpoint inhibition, and we have a study that is ongoing right now with checkpoint inhibition plus ibrutinib, BTK inhibition, checkpoint inhibition with lenalidomide. So yes, checkpoint inhibition is active in CNS lymphoma, not approved, not FDA approved in clinical trial settings. But yes, I mean, Hodgkin's lymphoma CNS relapse is very rare, and unless I see a biopsy, unless I see a CSF with cytology showing Hodgkin's lymphoma cell, you guys better check to make sure that it is indeed Hodgkin's lymphoma. It is more likely a secondary non-Hodgkin's lymphoma going into the brain, which is more common. So make sure your pathology is properly checked.
I agree with you. So with regards to the patients who are in need for brentuximab maintenance, do you stick to the criteria based on the Athera study, or can you extrapolate to patients, let's say, relapsing after 12 months?
I do agree, and that's that was the clinical trial definition. As you know, the clinical trial versus what is actually practiced in the real world is slightly not perfectly the same. So I do agree. That's why we call it the practice of medicine, where, we have to use judgments. If the patient, progress after 12.1 months, would that patient not benefit? And the answer is no. I do believe that patient will also benefit. It's just that in the study, we have to be very strict in order to, be eligible. It cannot have 12.0 plus or minus 3 months. Those things will not fly with the FDA. So we have to be very strict. But in the real life setting, yes, I would say if a patient relapse after 13 months, they will also benefit.
Sounds good. Any more questions from the audience? Dr. Ahmed, maybe?
Yeah, maybe. Well, brilliant talk. Thank you, Dr. Han. Very nice. A very nice discussion. I have a question about the AFM13. I get interested in this concept and the fact that you're using the cord blood NK cells.
Yes.
This is interesting. So this would be, this would be like allo, whatever cell therapy.
Exactly.
And if it succeeds further, I guess it'd be off-shelf product.
Exactly. I totally agree. This is a very interesting concept developed by our transplant team, Dr. Nieto, who's a collaborator. I mean, he's the PI and I'm a collaborator to the study. We have gotten patients in and they seem to tolerate very well. As you know, we have unlimited, that's what Dr. Nieto told me, that we have unlimited cord blood NK cells. I don't know about unlimited, but I'm sure we have a lot. So he's able to expand. And if we can, use a, unlimited supply, and then the AFM brings the cells together and eradicates the Hodgkin, I mean, this is gold. This is like, I mean, my gosh, this will be a home run. So hopefully, we'll see how the plays out. The AFM13 plus Pembro is a very exciting data also. So this drug will get developed. And I don't know how this will ultimately get FDA approval, but we'll see. I am excited to participate. And we have patients that, and we have slots for anybody who's interested and coming down.
Yeah, that's my question actually. So the patient needs to come down there.
Yes, yes, you'll need to come down here. Unfortunately, we cannot ship it there. So
Right.
yes, if you're interested, please, contact us, and then we'll be more than happy to consult, over, we could do a virtual consult and then and let you guys know what are the, the fine print eligibility criteria.
Yeah. Yeah, that would be like an added option actually to patients.
Yeah.
Absolutely. Very interesting.
Yes, thank you so much.
Thank
Any
you.
other questions? It was a pleasure. Thank you for this opportunity. Obviously, we hope to see you guys soon in real life and in in a webinar. Again, if you need how do I treat frontline, please don't forget to invite me.
Absolutely.
Dr. Lee, and hopefully next time we'll see you physically in Riyadh.
Yes, yes, and hopefully I'll be in Saudi
when the pandemic is over. So,
Great. Thank you, and have a nice day.
You too. Good night, and see you guys later. And be safe. Thank you, guys.
Thank you. Thank you, everybody. Thank you, Musa.
I think I'd like to remind you for next week lecture, which is how I treat frontline CLL by Dr. Paulo Gia. So please stay tuned for this lecture next week. And have a good night, everyone.
Thank you.
Thank you very much. Bye.
Bye.